India is already preoccupied in local academic programs tomorrow. We are happy to have two luminaries in the field of bipolar disorders. Dr. MS Reddy garu, the director of Bipolar Clinic Asha as guest speaker, and Dr. Suresh professor and Katuri as our chairperson. Today, the topic is very interesting and thought-provoking. This is a time to retire the diagnostic with bipolar. This title actually takes me back to our PC days, 4 decades ago, when we have only two entities for mood disorders. Endogenous depression is almost equivalent to major depressive disorder now, and MDP, manic depressive states. It's going to be very interesting today since it is by Dr. MS. Why? He is known for highlighting the controversies in academics, especially in bipolar disorders, with logical and reasonable solutions. Now I request Dr. J.V. Ramanrao garu, our CAD chair, to formally start the academic activity.
Yes, sir. Thank you very much, sir. Am I audible, sir?
Yes, sir.
Yeah. As Dr. MS was talking about, he's dealing with a very controversial topic. That too about time to retire the diagnosis of BD2. In fact, there are several proponents for this BD2 since several decades, and now, of course, there are several opponents too to dismiss the diagnosis of BD2. I think lots of literature is available on the net, and I don't want to take a lot of time because MS has come with a lot of information. I'm sure he's an authority on that. Let us going to hear to him. But before he, really argues about the, retirement of the diagnosis of BD2, I would like to just talk two, 3 points, for the confirmation and the existence of the BD2 diagnosis in the, lexicon of psychiatric disorders. One is that in our day-to-day practice, we do see definitely a group of disorders of bipolar spectrum, where we see recurring depressive disorders with one or two episodes of hypomania, and definitely they do not respond to the classic antidepressant medication, and we need to keep them on mood stabilizer. Naturally, this is the most of the patients they respond well when we add on a mood stabilizer. That is number one. Number two, when we really try to club all these patients together, maybe most of the patients they might not be really happy to be labeled as bipolar patient because bipolar 1 patient because that's a much more severe problem, and they're more comfortable with bipolar 2 disorder. That is currently one of the stakeholders. And also coming to the biological basis and the genetic correlation, whatever that is available, it was found that most of the patients with bipolar 1 and bipolar 2, family studies, they indicate that they breed true, like, the relatives, they have more number of bipolar 1 in case of the index patient who is a bipolar 1 patient. And the same thing is true with the bipolar 2, group also. That is number two. Even to claim that bipolar 2 is an independent diagnostic entity by itself. Number three, in the DSM-5 groups, when they were trying to study the various validities for various diagnostic entities, it was found that bipolar 1 and bipolar 2 are having better diagnostic validity scores when compared to the so-called MDD and GAD, because we routinely diagnose MDD and GAD, but their diagnostic validity is much lesser than bipolar 1 and bipolar 2. So what the hell we are going to think of only retirement of the bipolar 2 disorder when the other so-called common mental disorders are having less validity? I think all these questions Dr. MS is going to answer in his talk. And with this, I try to introduce our chairperson, Dr. Suresh Garu, who doesn't require any introduction because he is in touch with all of us on social media, and most popular psychiatrist, and he is the recipient of the prestigious awards like Manasa Hospital Oration Award, and also he is from prestigious institutions, PGI Chandigarh, NIMHANS Bangalore, and a very popular teacher and a very passionate teacher in psychiatry. And I don't think he doesn't require any introduction. The most sociable person in our group. So thank you very much for giving me this opportunity, and I request Dr. Suresh Garu to go ahead with his comments.
Thank you, Dr. Raman Rao, for your kind words. And as it is customary, I have to introduce the speaker, Dr. M.S. Reddy sir. But otherwise, there is no necessary to introduce such a luminary to the public. But for us, M.S. Reddy is known as Bipolar Reddy. And he himself coming out with a topic saying that it's time to retire the diagnosis of bipolar disorder is a little paradox. Quite popular. Everybody is waiting after seeing the title in the invitation. A lot of people are waiting. What is happening? What is this title? Why is MS Reddy so popular with bipolar? Says that bipolar is going away. In fact, few years back, we had a discussion. The same talk by Dr. M.S. Reddy saying that there are soft symptoms and signs of bipolar disorder. Even wearing flashy clothes, having a red car, this type of things are soft signs of bipolar disorder, and we can make a diagnosis based on that. That was his take home message few years back. So what he is going to say now, we'll see. And before the talk, I would like to introduce, as I said, it is customary. He is director of Asha Hospital and Asha Bipolar Clinic, ABC, that is antecedent, behavior, and consequence. Antecedent joined Asha, B joined bipolar, C consequence, head of the bipolar clinic and prominent person in the bipolar disorders. Anybody bipolar, we have to remember. Anyway, his primary education has been MBBS at Tirupati during 1978, MD Psychiatry, Christian Medical College, Vellore 1984, and then Diploma of Christian Medical College, Vellore 1982. He has been a member of past president of Indian Association of Private Psychiatry, past president of Indian Association of Biological Psychiatry, honorable secretary of Society of Bipolar Disorders, editor of Indian Journal of Psychopharmacological Medicine 2006 to 2017, that is 11 years, which is a record, and council member of Asian Network of Bipolar Disorders and council member of Asian Association of Neuropsychopharmacology and member of the editorial board of World Journal of Psychiatry. His experience 84 to 86 lecturer in psychiatry, Christian Medical College, 1988 to 2008 consultant psychiatrist at Medinova, Hyderabad, and from 1998 to 2012 consultant psychiatrist, Apollo Hospitals, Hyderabad. And he has been a main person doing mood disorders, anxiety, OCD, psychotherapy, and counseling. I still remember his Bhagavad Gita and psychotherapy, which was really interesting at that time. He made it very contributory. And awards and recognition, there are so many, plenty. If I start reading all those things, I think the total 1 hour session will go away with this. So, anyway, few awards. Trained in psychiatry at CMC, at which time he received the Florence Nicholas Prize for the best student. So పువ్వు పుట్టగానే పరిమళించింది. Even at CMC level, he was a very popular, best outgoing student. Recipient of Dr. Boer Indian Medical Association Oration Award, recipient of HUTS IMH Oration Award 2014, healthcare management course at the prestigious Business Institute of Hyderabad, chief of psychosocial rehabilitation project in association with UNICEF in the tsunami period in the coastal districts of Andhra Pradesh, which is remarkable. Even few years back, he has done this. And as I mentioned, bipolar means we always remember him. And he has come out with a controversial title. Is it time to retire the diagnosis of bipolar disorder, and what has made him, what are his views, what are his scientific evidence, what is his take on. Let us first hear, and then there will be a lot of questions which Dr. M.S. Reddy will be very happy to answer. Thank you. Over to Dr. M.S. Reddy, sir.
Thank you. Thank you very much. I think Dr. Suresh Kumar, so nice of you, so kind of you for a very kind and then introduction. So many thanks to you. Maybe I feel not like that's an elaborate thing. Like I am your MS Reddy, nothing more than that. And I thank the AP chapter, the office bearers and the executive committee for giving me this opportunity to say these few words today. Thanks once again. Thank you all. The topic I chosen, I think Dr. Raman Rao as a CMA chairperson fired the first salvo. Do you have a data to say that is it time to retire? I think 2-3 questions, 1, 2, 3, 4 points which he has asked. Maybe let me see some of them whether I can answer. Genetics, maybe I'm not touching today. And let me see whether I can try to finish it in about half an hour so that we'll have interaction. Genetics and breeding, true, I'm not touching that. But when it comes to the treatment, that is one of the main areas which prompted me to take up this topic and then talk on this. And then the small group of, and then the bipolar 1 and then bipolar 2, the diagnostic validity is much more than many other psychiatric disorders. Yes, maybe, but the diagnosis wise, there is some ambiguity. If you ask me, if any of you ask me, what is the simple reason? I think Dr. Suresh Kumar asked, you are talking so much of bipolar disorder, and then today, why are you talking about retiring this particular diagnosis of bipolar 2? One and then only answer, the first answer which comes to me is that in the therapeutic arena, in the treatment arena, diagnosis of bipolar 2 disorder, I feel, personal feeling is that it is doing more harm than helping the group of patients. I'll come to it a little bit later. So it's a time, is it time to retire the diagnosis? Like maybe some of you can say that it's a little bit controversial statement, some bold, is it necessary? Is it required to talk about it also? But I feel here the point is, I'm trying to put across some of the data, some of the points, some of them are personal. The idea of this topic is to raise questions, to make especially some of the youngsters feel that what is that he's talking about? Is there something truth in this? Can we think of it in a different perspective? Can we look at it from a different perspective? Why should it be like this? Why can't it be like this? It's only to raise that questions and then to look at this from a different perspective and nothing more than that. I'm sure some of the seniors won't agree with me. There are a lot of criticism on this also, but still that is the reason why I wanted to present. Let's go to the, now like in the first slide. Why do we make a diagnosis? First of all, I think this is going to be the most important thing when we talk about it. The diagnosis is the most important thing for any medical practitioner. He has to make a diagnosis. The reason is that diagnosis indicates prognosis. I think all of you know that, and that is the reason we are talking about it. Diagnosis indicates prognosis. And when we talk about it, simply I say that when somebody comes to you with a medical thing, somebody comes with a cough and fever, you make a diagnosis of acute respiratory tract infection. The same thing can be the tuberculosis. The same thing can be bronchogenic carcinoma. The diagnosis indicates prognosis and also directs therapeutics. As medical practitioners, we all bound to make some wrong diagnosis at some point of time, but diagnosis is the most important thing. Whether it's wrong or right, you have to make at least a provisional diagnosis before we proceed further. Why should I make a diagnosis? As a clinician, this is what I want. I want my patient who have come to me to be asymptomatic and come back to pre-morbid self. Now, what do I offer? I offer some treatment. Whatever may be the kind of treatment, I offer some treatment. How do you plan your treatment? That is what I said. Diagnosis directs therapeutics. If it is, I can again go back to the physical, like a medicine, acute respiratory tract 1, tuberculosis 1, malignancy is 1. It's a diagnosis based on that. Sometimes I can be wrong. but it's the diagnosis which is most important. It directs therapeutics. For this, you can convey to the patient, this is what likelihood of it, this is what it's going to be, this most likely is going to be the outcome, that's what you're going to be. And that's where we fall back on nosology, whether it is DSM-5 or ICD-11 or whatever it is, we look at it to make some diagnostic, or like entities. How does this come to that? The concept. This is the core issue. You start with a concept. Based on that, whatever may be the genetics and then the treatment duration and the natural course and treatment response, genetics, family history, lab diagnosis, whatever the criteria you take, and build a concept. From that, you derive a nosological entity and put it on the diagnostic criteria. From there, diagnosis, treatment, asymptomatic, and then ultimately the benefit is to the patient. He has to become asymptomatic. Patient is not really bothered about what diagnosis you make, but most important thing is whether I'm going to become all right doctor. It's my responsibility to make a diagnosis. I clearly heard Dr. Raman Rao saying that some of the stakeholders may not like the diagnosis of bipolar 2 or bipolar 1, may not be. But most of them, it's bipolar is bipolar. It may be that. This is the reason. Today, those few words what I'm going to talk, I'm going to look at the concept of bipolar disorder 2, how it evolved, and what exactly is that. This may be a direct attack on the diagnostic entity. I say diagnostic fragility and ambiguity. Why did I say this? All of you know, including the first year DPM student, one episode of mania is enough to make a diagnosis of bipolar 1. Of course, there's a controversy like, is it unipolar mania, bipolar, whatever it is, let's leave it. One single episode of mania, bipolar 1. Suppose there is one episode of hypomania. Is it bipolar 2? I think some of you may not be very clear about this particular point. That's why I want to highlight. How many episodes of hypomania do you need to make a diagnosis of bipolar 2? 5? 10? 100, sir? Suppose somebody had a 200 episodes of hypomania. Can you make a diagnosis of bipolar 2? Absolutely no, sir. One episode of mania, bipolar 1, 1,000 episodes of hypomania does not become a bipolar 2, because to diagnose a bipolar 2, you need at least one episode of major depressive disorder. Why that? Whoever has conceptualized that, why a core in bipolar disorder, mania is the defining symptom. Bipolar 2, hypomania is the defining symptom. When they could give so much of validity for mania, why hypomania has been, you have hypomania, but until you have MDD, you cannot become bipolar 2. That's one starts with. Then not severe enough to cause marked social and occupational impairment is very, very, very important. Any diagnosis, any kind of a disorder, any disease, there has to be some social occupational impairment. And 4 days duration is enough. At this point, I say all of you know, a mania which is supposed to be severe, what is the duration required? If some of you think I'm hair splitting, right, I need to do that, sir. For a severe illness, you need 7 days. Generally, common sense dictates that if it is a milder illness, I need to, I can watch him for a prolonged time, 2 weeks or 3 weeks. But here they made it 4 days. Well, what's the reason? Severe symptoms, even then you need 1 week. You have to wait for 1 week to make a diagnosis of mania. It's a very mild, doesn't produce any impairment, but 4 days is enough. Why I'm trying to, actually quite a lot of research workers say that not even 4 days, let's have 2 days. I was never able to understand that. Then, this is the core, sir. Depressive component in the long-term natural course of bipolar disorder. We all know that in bipolar 1, the depression is to mania is 3:1. You know what is in bipolar 2? 33:1. If I want to simplify to some of the youngsters, suppose there is a patient with, you look at 100 days in the history of bipolar disorder 2. 100 days in the history of now you may again think that I'm splitting hair. No, in 100 days, 50 days he will be euthymic. The rest of it, 33 days he will be in depression. 1 day he will be in hypomania. I'll come to it a little bit later. And based on that 1 day, 2 days, or 3 days, 4 days, very less severe thing, we are making a diagnosis of, and in the process, depression is getting sidelined. This is my main complaint is, which I'll come to it a bit later. And when depression gets sidelined in the treatment, there's always a risk of suicide. I think we all know that. I don't have to talk anything more about it. This is the reason why today, on the last decade, I've been talking about it. Actually, today maybe like now, I was a little bit more polite in making that is it time to retire. 10 years back, I said that it's time to bury bipolar 2. Therapeutic ambiguity. This is diagnosis of bipolar 2, in my opinion, is doing more harm to large percentage of patients rather than it's helping them. I go back to Dr. Raman Rao's word when he said that there are a group of patients in MDD where they did not get improvement with like 90%, but when you add lithium or mood stabilizer, they become better. Sir, but that does not make the diagnosis of bipolar 2. It's only the augmentation. That's it, nothing more than that. What is the harm? This is where it's coming to. These are not my words, sir. I'll show you the slide later. Counting the days from bipolar 2 to be the true bipolar 2 disorder is a myth. I'll also stick my neck out and say that, yes, it seems to be. Then, at this point, some of you may be wondering, whoever has proposed this concept, it's almost exactly half a century back, 1976. Why did these are all very great, research workers, Frederick Goodwin, Dunner and Phoebe, Chamil Gerson. These are the 4 people who proposed this concept. What I say is that no, I absolutely am nobody to criticize that. I'm too small a fellow to even talk about the concept of it. But we have to look at the context and then time period. 1970s. It's a context and history which is important. These great authors would have felt that bipolar disorder is not being diagnosed correctly, in the sense a lot of patients with the milder symptoms are being missed out. And that is why they wanted to include this concept of hypomania. That is well-intentioned. The intentions were absolutely right at that point of time, but you have to look at half a century later, possibly landing in a different path. And when it started, it would have been more relevant, but now I feel that there are a lot of problems. What is the biggest problem is including irritability as a diagnostic criteria in bipolar disorder is a major problem which is creating a havoc. It used to be elation only. Now we have included irritability also. Why did you include? We are missing some other cases, which I think some other meeting, if I have a chance, I'll be very happy to discuss with you. This is one thing which was not there 50 years back. Then maybe 1970s, there was no insistence on you diagnose mood disorder, you have to go for mood stabilizers. No, that concept was not there even when we were students. This is a later concept. And lastly, advocacy for non-use of antidepressants. 1970s, when Dunner and Phoebe proposed bipolar 2, these 2 concepts like you have to use mood stabilizers and then don't use almost antidepressant, it was not there, and possibly some of the cases were missed, and irritability was not there. That is the reason at that point of time that context-wise it would have been maybe more sensible when they made the diagnosis, but now it's becoming a little bit more problematic and then doing more harm. That's what I feel. This right, 1976 they proposed. First time bipolar disorders came in 1980. It's the first time in 1994 we had the diagnosis of bipolar 2 in DSM-4. Till 1994, sir, there was no diagnosis of bipolar 2. Once again, one more thing I say, ICD-10, if you are one of the strict followers of ICD-10, you cannot make a diagnosis of bipolar 2. Only ICD-11 has introduced it. So ICD-10 never had the diagnosis of bipolar disorder. And this also came in 1994. This is what I told. One episode of mania is enough. Any number of episodes is not enough. You need to have at least one episode of MDD. Why? That means that whoever has proposed the criteria are not very confident. They're shaky about the 4 days and then minimal duration about this hypomania. So they insisted that there has to be an episode of depression. ICD-10, no bipolar 2. Very clear, sir. Only ICD-11. Now here, I'm not looking at the reliability, but I look at the validity of the diagnosis. And more than utility, any diagnostic should have a therapeutic utility. If not now, at the later part, it has to be. Here, I say that it's more of a harm rather than bipolar, like in the diagnosis, which I'll come to it later. Right, this is what I was talking about. Hypomania, at least 4 consecutive days, not severe enough to cause marked impairment. This I don't, I want all of you to remember the next 10 minutes. 4 days is enough, not severe enough to cause marked impairment. Not severe enough, not severe enough, no social occupational functioning. This is 7 days and sufficiently severe. Please think about it, sir. A severe illness, DSM-5 requires longer time. A milder illness, 4 days or 2 days is enough to make a diagnosis. It doesn't sound commonsensical and doesn't sound logical. That's where I question that. Please focus on this. This is a paper now, like from the textbook I have taken 2013, Gordon Parker. Gordon Parker, even today, is a great proponent of bipolar II disorder. This is one of the chapters I have taken. If you look at this, bipolar II, let's not forget about bipolar 1. If you look at this, 75% of the average duration of mania, hypomania, 75%, I want to count, sir, 19, 27, 27, 2. This is 4 days. 75% of the patients with hypomania, bipolar disorder, the hypomania lasts only 4 days. It's only in 25% it extends more than 4 days. Now, I keep talking about this again and again. A milder illness, in 75% of the cases, lasting only 4 days. You make a diagnosis of bipolar 2. So what? I'll come to it a bit later. I'll come to it again when it comes to the therapeutics. So this is what? 75%, which again here is bipolar 1, it's different. See again here, 2, bipolar 2, more than 1 week, 27%. I'm again coming to that. Sir, once again, bipolar 2 disorder, pathognomonic is hypomania. Only in 25% of the cases, it's more than 1 week. What kind of damage it can do within 1 week, especially illness which is less severe, very, very less severe, so that it won't produce functional impairment. Why are we in such a hurry to make a new diagnosis and go ahead with the treatment? Let's think about it. Let's think about it. Some of you may say that, yes, within 4 days, he can do a lot of disturbance, a lot of problem, a lot of impairment. No, sir, if it is a lot of impairment, it's no longer hypomania. If it is psychosis, no longer hypomania. If it is hospitalization, no longer hypomania. It goes on to mania. So, an illness, a disorder, where one component of it is does not last for more than 4 days in 75% of the cases, and where it is very mild. Based on that, we are making a diagnosis of bipolar. So what? I'll come to it. As I told, bipolar, if you look at this is from almost 20 years or not. Jet study, one of the 25-year-old follow-up study, if you look at bipolar 2, 44% euthymic, 52% MDD. Look at the hypomania percentage here, 1%. So, for every 52 days patient spends in depression, 1 day he spends in hypomanic period, according to this study, which is a very popular study. It's, I think, is widely quoted and widely cited. Jet study. Bipolar 1, even here, it's not like, it's only minimal mania. Let's not bother about it. Now, this is another important slide. Bipolar 2, the percentage of illness patient is depressed 81% of the time. In case of a bipolar 2 disorder, if you look at hypomania and depression, 80% of the time he is in depression. It's only 20% of the time so-called hypomania. I was actually giving a very liberal this thing here. I just told that out of 53, it's only 1. So what I'm trying to focus is that, of course, in bipolar 1, it's 3:1. Here, you have a disorder. Hypomania is supposed to be the pathognomonic. But one episode of hypomania alone cannot make bipolar 2. You need to have depression. And people suffer from depression for 80% of the time, 90% of the time. And you call it as a bipolar disorder and then you treatment. And then why do you have to bother so much about the depressive component? I think all of you know that. 60-fold higher during depressive state, the suicidal risk is 2017. Suicidal behavior in bipolar disorder is, it's not who is the patient, it's when. The more longer the patient is in depression, the risk of suicide is high. This is one point I want you to remember again. Now, this is the core issue. This is the main issue. I have been vehemently against the diagnosis of bipolar disorder, especially 2. Sir, you make a diagnosis of MDD. you treat antidepressants. You make a diagnosis of bipolar 2 or 1. First thing is go to mood stabilizers and no to antidepressants. Mostly. I think I am right. You make a diagnosis of bipolar disorder, you can't treat a patient without mood stabilizer, which I also have been fighting about both the concept, the term mood stabilization, and also this concept, and infrequent use of antidepressants. This is the dictum. This is the thing which is being repeated in every textbook, every journal, every paper, which I feel, which was not the case in 1976 when Danner and Five has conceptualized the term bipolar 2. This is what has changed, and now this is what is doing most of the damage. As I told, MDD, antidepressants, RDD, antidepressants. Bipolar 2, no antidepressants. It's a mood stabilizer. Which is mood stabilizer? Lithium, or valproate, or lamotrigine. I'll come to it, what is the data which we are going to have. This is a 2003 paper, Amsterdam's. Antidepressant monotherapy in bipolar 2 depression. Patients with bipolar 2 depression treated with, every time I see this, I don't know what to do. As a clinician, I'm a clinician, I'm not a research worker. The lowest effective dose, shortest possible time. This is the worst statement, which you can very easily write on paper. How do I ever know that which is the lowest? How do I ever know shortest possible time? I say that this is one of the main reasons we don't treat bipolar depressions with antidepressants effectively. We are always worried. This is a minimal dose. This is a minimal dose. No, don't go for too long time. Don't go for more than 3 weeks. And you don't treat them properly. And where is the evidence? Clearly you see that. Very limited data in the literature to indicate that low dose or rapid discontinuation is more effective than continuation therapy. This has actually been told 2 decades back. Available data suggests that continuation of SSR therapy may be more beneficial. Yes, some of you may say that you're picking up some of the specific papers where your viewpoint is now reflected there. Yes, definitely. The point is that this is what I see in my clinic. This is the paper which is published in just about 15 days back, 13th March 2024. The superior 12-week antidepressant monotherapy. I want all of you to focus on this. 12-week therapy, antidepressant monotherapy, sir. This is an oxymoron when you talk about bipolar disorder. Antidepressant monotherapy, no. Even a DPM first year student says, no, sir, it has to be with more stabilizers. Superior effectiveness with clinically meaningful increase in treatment, less clinically meaningful hypomanic symptoms with lithium monotherapy. This particular paper very clearly shows today that in this 2024 March, 12-week antidepressant monotherapy, superior effectiveness without much of a switch compared with lithium monotherapy. How many of us are willing to take this kind of a statement, which is going to be the very, very important thing here? CanMed says that as far as possible, avoid antidepressants. But ISBD task force says that you can consider that. I am coming now to an interesting proposition. I don't know how many of you agree with this. Now, can it be speculated that mood stabilizers may inhibit the mood lifting effects of antidepressants? Sir, the dictum today is that whether it is bipolar 1 or 2, if we have to use an antidepressant, it has to be always under the cover of a mood stabilizer. Am I right? Antidepressant monotherapy is no. Antidepressant, it has to be under cover of mood stabilizers. This particular paper saying that you are giving mood stabilizers is one of the reasons why antidepressants are not showing the required effect. This is not very clearly visible here. I'll show the other slide, next slide. Look at this. Please focus on this particular slide for a second. Antidepressant monotherapy in treatment refractory bipolar 2. When you diagnose a case of bipolar 2, patient is in depressed phase. What is the stage 1 treatment? Patients with bipolar 2 depression are usually treated with either mood stabilizers or second generation antipsychotics. I think all of us agree in that. Clinically, that's what you teach your students and what you practice. Bipolar 2 depression, what do? Start lithium or valproate or lamotrigine or quetiapine or olanzapine, right? Right. If it is successful, point, it's okay. If it is not successful, then stage 2, bring in SSRIs. bring in SSRIs under cover of mood stabilizers. Still, the patient is not responding. Let's look at the scenario. Bipolar II depression, bipolar II disorder, depressive episode. Treated with lithium, whatever the other drugs, not responding. Add antidepressant, SSRI. Wait for some time, 6 weeks or 8 weeks, still not responding. Then what do? Look at this. Withdraw mood stabilizer. If all else fails, mood stabilizer withdrawal and then antidepressant monotherapy can be a useful option. So what does it mean? When you give antidepressant along with mood stabilizers, the mood stabilizers are blocking the effect of antidepressant in finally not giving the required effective antidepressant response in that patient. This sounds a little bit like some of you may be wondering what's that he's talking about is something totally new, and then something it doesn't sound logical, whatever I've studied. This paper, if you look at it, should medication with little or no efficacy be prescribed in treating bipolar disorders? This is from Bipolar Disorders 2021, Journal Bipolar Disorders. Forget about this. I'm not discussing this. When you give antidepressant, let's look at SSRIs. It's an effective antidepressant. But when you combine with mood stabilizer combination, here, the efficacy of SSRI is muted. So my point here is that all along the teaching was bipolar disorder, when you give antidepressant, combine with mood stabilizer, under cover of mood stabilizer. Now, another concept is coming up saying that when you give antidepressant along with mood stabilizer, the mood stabilizer itself is not allowing the antidepressant to give required effect. So it's blocking that. So withdraw mood stabilizer, patients may improve better, right? Some of you may be saying that, okay, he's going to go into hypomania or mania. That's why you're saying that is improvement. No, not that, sir. Definitely, it's only a depression response, not going into mania, hypomania. Now, broadly, next few minutes, I'll complete this. Why is lithium recommended as second-line agent for bipolar II depression? If you look at this, CanMat, I'm quoting next few slides will be completely from CanMat. In the only recent placebo-controlled study, lithium was not superior to placebo in bipolar II depression, but every textbook says that give lithium. First line of choice is lithium. Venlafaxine was better in this study, but they say that it was only 0.6, it's not 0.8, so 0.8 to 1.2 would have been better. But as clearly told that only recent placebo-controlled study, lithium was not superior to, but the traditional teaching goes that bipolar II depression, first drug is lithium. It's like, now I think this is a fairly critical statement which Michael Gatlin came out with in 2019 Bipolar Disorder Journal. Data impress, but belief seduce. I think this is something which all of you should read this. In the case of lithium as a bipolar antidepressant, I would suggest that our gratitude to this remarkable medicine, which is lithium, which was helping us for 7 decades, which revolutionized the treatment of bipolar disorder, it has made us less than neutral and reliable observers about the scope of lithium efficacy. Multiple meta-analyses have demonstrated that there is no difference in switch rates between antidepressants and placebo. SSRI is not much. TCS maybe. Warnings in textbooks and review papers and expert guidelines continue to abound about the dangers of antidepressants in bipolar depression and continue to suggest lithium. Then, CanMat says that should antidepressants be used in bipolar II? Here you look at this. Again, CanMat also says that meta-analysis that compare rates of antidepressant-associated mood elevations. Not much. It is significantly less frequent and almost always into that milder state rather than manias. So ISBD task force report on antidepressant conclude that it may be favorable, but how many of us in the clinical practice can teach? I may be writing, but how many of us confidently can answer my student's question that yes, you go ahead and then give antidepressant, maybe without mood stabilizer. Over the last 1 decade or 2 decades, this concept has been drilled into our mind. Mood disorder, mood stabilizer, mood disorder, mood stabilizer. Now that's the reason. Acute management of hypomania. Look at the literature here. Look at the literature. Many standard medications for mania, including lithium, have not been studied in hypomania. Why, sir? You have a diagnosis of bipolar II disorder, which has been existent for the last 3 decades in DSM-5. Why there? No, you can't ask that why they have not studied, but why it has not been studied. And they ask us to extrapolate antimanic medications to hypomania. So the literature is very vague. The diagnosis itself is very ambiguous. That is the reason they are not able to go into the studies. Maintenance. First, what is the maintenance therapy? First of all, maintenance. I say it's an RDD. You say it's a bipolar 2. And then once you say bipolar 2, you start on prophylaxis. How long, doctor? Long. Continue for long. And drug is lithium, which just now we told that it may not be effective. And quetiapine and lamotrigine. Why should we? The moment you make a diagnosis of bipolar, it's a lifelong prophylaxis, which is sometimes not warranted. Now, all of you may ask, yes, what is your problem? Okay, you say it's RDD. I say it's bipolar 2 disorder. What's your problem, Dr. Reddy? Why are you making such a big fuss about this diagnosis? I'll show you this. We talk about symptomatic recovery. We talk about functional recovery. There's a gap between symptomatic recovery and functional recovery. Why there is not much? This is a paper which is published in 2022 in a bipolar disorder. It's a large study. It's actually, it's like a cohort. It's almost 13 cohorts from 7 countries. Global bipolar cohort, collaborative bipolar disorder. In this, it has been published. What are the predictors of functional impairment of bipolar disorder? Lower functioning was associated with depressive symptoms in 10 out of 12 cohorts. Sir, this particular study, which has come from 7 countries, there are 12 cohorts, out of which 10 say that the lower functioning was in the bipolar disorder is associated with depressive symptoms. Why are there depressive symptoms in bipolar disorder? The reason is you are not treating them well. You talk about least effective dose. You talk about the shortest duration. You talk about don't give antidepressants alone. You give about antidepressants plus lithium or lamotrigine and something. Obviously, you are not treating. This is the most controversial thing today about the depression of management of bipolar depression. I think this is an eye-opener. Depressive symptoms in 10 out of 12 cohorts. That means that according to this paper, we are not treating bipolar disorders sufficiently, effectively, conclusively, leaving the depressions aside. It's only because of that they don't have functional, they have this functional impairment. These are all fine. Then one more I'll show you. Greater total number of psychotropic medication. If the patient has depression, I'll treat him with antidepressants. If patient has bipolar disorder, I have to start him on lithium or valproate or lamotrigine plus some other drug. Polypharmacy is one of the biggest problems in bipolar disorder because mood disorders and mood stabilizers, they go like almost like Siamese twins. This is the thing. If you look at this, the predictors of functional impairment, why certain patients with bipolar disorder not having a functional recovery. Number one is that you have not treated the depressive symptoms effectively. Number two is that you are putting them on too many drugs. Now, I think partly I could answer Dr. Raman Rao's question, why I am against this diagnosis of it. As I told that more than helping, it is doing therapeutic harm. That's the reason why I'm saying that. Now, I come to this Jin Mali's paper. Jin Mali is right now the president of ISBD, 2019 ACTA, counting the days from bipolar 2 to bipolar 2. This is what exactly the sentences I have taken from the paper. Clinical utility of a diagnostic label is underpinned by, in the case of BD2, lack of clear boundaries contributes to misdiagnosis. Opportunity cost. You're not treating the depression. That is what the opportunity cost. Direct cost of AE, you're giving them polypharmacy and then unnecessarily giving too much of medication, then impairing the functional recovery. And then you dump all this bipolar 2, which I feel that is not a current diagnosis in your cohort of bipolar patients, and you keep doing all your neuroimaging and then a whole lot of genetic studies, garbage in, garbage out. Nothing else is happening. So it's going to muddle the data. And the decades of data will go waste down the drain. That's why we need to be much more specific. Same Jin Mali's paper, 2019, Canadian Journal of Psychiatry, where he said that bipolar 2 disorder is a myth. We feel the concept of bipolar 2 has run its course and served its purpose. Research has failed to demonstrate that a distinct subtype exists. Illogical definition of hypomania, which I also agree. Non-clinical, non-harmful elevation. Sir, this is one thing. That's why I said that 75% less than 4 days, non-harmful, not much of a social clinical impairment. Is it phenomenally accurate and ethically appropriate to pathologize that? overlaps considerably with borderline personality disorder, which in my clinical practice, I feel a lot of times borderline personality disorder is being wrongly diagnosed as bipolar disorder. But there's so much of literature on that. The problem is you misdiagnose a borderline personality disorder as a bipolar disorder, finish. The patient has to be in a lifelong prophylaxis and 3 or 4 drugs. Average number of drugs in bipolar disorder is 3, polypharmacy, which impairs his functional recovery. It's important for classification systems to examine the evidence and revise diagnosis rather than hold on to an inaccurate diagnosis for fear of what changing it will bring. This is a statement from the Jean Mali. Hence, we propose the abandonment of bipolar II as a diagnostic category. This is what he has told in 2019 Canadian Journal of Psychiatry. Going forward, the existential crisis of bipolar II, International Journal of Bipolar Disorder in 2020, he said it's our opinion. I also put my name saying that it's MS Reddy's also opinions. MS Reddy also joins this group. It is our opinion that from a conceptual viewpoint, eliminating bipolar II disorder would be the most intellectually honest decision societies and classificatory systems can take. And he did it. Jinmali is from Australia. 2020, Royal Australian New Zealand College of Psychiatrists Committee Guidelines for the Mood Disorders. They turned the upside down from down under in dismissing bipolar II disorder as a condition. Today, at least one clinical guidelines, Royal Australian New Zealand College, they do not have bipolar II as a diagnostic entity, which ICD-10 did not have till yesterday. These are the important points. This is the last slide of mine. Why I opposed it, why I say that it should be retired. Hypomania is to, depression is to hypomania, 33:1. Less than 4 days, for 75% of the times it is less than 4 days, and clinically social occupational impairment is very less. 4 days with a mild illness, world is not going to collapse if we don't start him on the so-called mood stabilizer and prophylaxis, sir. Clinically, this is the clinician's anguish. This is what I see every day in my practice. And I find it difficult to put him on, talk about this, lifelong prophylaxis you need to take, and you need to take, in my opinion, a lot of the so-called drugs which just do not do anything for the sake of it. Am I right? And I don't treat depression properly. All the time saying, no, there can be a switch. No, you are producing a switch. You are producing a rapid cycle. Why do we forget it? Unwarranted polypharmacy. This is biggest criticism of mine. Prolonged prophylaxis, absolutely not necessary. And what you are supposed to be treating, you don't treat it properly. Depression, which is supposed to be the most, majority of the patients mention that you don't treat that properly because of the fear of switch. And you give polypharmacy, more functional impairment, higher suicide risk. So these are the few reasons why I felt, I know, maybe some of you feel that I picked up some other papers which are more suitable, but this has come from my clinical practice over the period of last decade. About a decade back, I told that, no, something is not going right here. That is why we need to have a rethink. I request all of you to have a rethink, nothing more than that. Just raise some questions, right? After that, all of you are very highly intellectual, very wise people. Some of you having a much more than clinical years of experience than me. With these few words, thank you so much. Thank you so much once again for giving me this opportunity. And thank you all, Dr. Suresh Kumar, for very kind words. Dr. Raman Rao for setting the ball rolling, I think, very nicely. Thank you so much. You raised the questions. And the AP chapter organizing committee and CME committee. Thank you, sir. Thank you so much.
Thank you, Dr. MS Reddy. I think you have very intelligently put few references to justify your concept of bipolar disorder to not occurring. There can be a lot of other references which people can put favoring it. And what do you want if bipolar 2 is not the existing? What are those patients you want to do them? How do you want to treat them? Where do you want to put them? That's my question.
Can I straight away answer that question, sir?
Yes, please.
Sir, do you remember there used to be one diagnosis called simple schizophrenia some time back?
Yeah.
Do you remember diagnosis called pseudo-neurotic schizophrenia some time back, sir? What happened to those patients? Where are they now? That's one of the biggest mistakes psychiatry has done, is that making an entity of simple schizophrenia. They're gone. They're gone. These are most of them can be recurrent depressive disorders with 4 days of, as I think Jin Mali put it, non-functionally impairment, milder changes which will not produce any impairment, pathologizing that. I think he has very clearly put that. Pathologizing that and going ahead with treatment may not be a correct thing. Suppose tomorrow you get a biomarker exclusively separating. I'm going to do that. There's no doubt about it.
The
Yeah, of course.
chairperson, can I talk, please? Can I have
Yes,
5 minutes?
yes, Prasad Rao, most welcome.
Yeah, first of all, I would like to say that one, MS Reddy is a very intelligent person. Second,
Thank you so much.
Second, he put his argument based on his own thoughts. But having said that, I would start with only few points to counter that. Definitely, I'm not ready to bury it. The good thing what happened in MSD in 10 years, sitting next to me, very closely, we have tea every day. So instead of burying it, he said, let us not burying it now. Let us actually do whatever he said, that retire, which means he's still not burying it. But having said that, 3 important points I have. I would start with the most important recent discussion which happened about the fundamentals of the psychiatric diagnosis, why they are not reliable. I will not go into the debate, but most of you know this point. This happened in the Glasgow conference, where the top psychiatrists felt that we continue to be in that, and I think everyone knows that. But my second point, which is more important, he has quoted Jude's study, but there are 3 other studies which did show. First, there are 3 points which I would like to highlight from the summary of all the 3 studies. Most patients spend longer time in depression than in mania and hypomania. That's a well-known fact. The reason is mania, they get admitted, and within a few weeks they get admitted. And the percentage of time, as you quoted, I agree. And all the 3 studies more or less quote the same thing. But the most important point which he didn't, as a construct, Akiskal has said 7 varieties, out of which few are remaining. And I'm sure each one of us will have 1 or 2 patients of all the 7 classificatory of Akiskal, which means, see, our patients do fit into one pigeonhole. They might not fit into another pigeonhole. So bipolar depression as an entity, I think it exists very strongly. Now coming to DSM-5 and ICD-10, which he intelligently put it, and I would agree with him, because ICD-10 stayed for donkey years without much research. Now what happened in the recent times, ICD-10 and DSM-5, both groups are same experts. See, what happened is the American experts now percolated into the ICD-10. So they introduced that concept. So that's what it is. It's not that, but bipolar depression as a concept. And 40 years in the practice, each one of us, the seniors at least, know that we have patients, difficult patients who are bipolar due to depression. In fact, I just want to quote just 2 more evidences from my side. In fact, right now, for example, we can differentiate bipolar II depression from MDD on some constructs. And this is a recent review published in the year 2019. And if you want, I can share with you the name, but suffice for me. And finally, my point, which is most important, pharmacologically, he talked about antidepressant and the mood stabilizers, but he didn't talk. So what did CANMAT guidelines talked about? They talked about 5 molecules: OFC, lurasidone, quetiapine, and I would, for the sake of the large academics here, OFC has NNT of 5 and NNH of 11. NN of 5 is a very good one for any molecule. Now, quetiapine, NNT is between 5 and 4, and NNH is 4, which is probably quetiapine has, and NN4 is for sedation. But for the other side effects, it is much less. Now I'm coming to lurasidone. The NNT is slightly high. It was 7 in the older review, and the most recent review published in 2022, NN2 has come to 5, but NNH is 12, which means it's a safer drug, but probably less efficacious. And then coming to the other 2 molecules, cariprazine, at this point of time, the NN5 is 5. So what I'm trying to say, pharmacologically, for bipolar depression, we forgot to mention that ECT is the best treatment. After the patient who is, and the rule of the thumb, as we are taught when we are young psychiatric residents, we are taught depression, if the patient is not responding after so much time, consider that your diagnosis. That used to be, I think Professor Kurella used to say. Now, with this bit of my thing, ambiguity in diagnosis doesn't rule out or bury a diagnosis. I agree with MS Reddy. During my residency, I was shown by Raghuram, none other than Raghuram, a case of simple schizophrenia. After that, I think we have not seen. And epiphrenia we have seen during that time. But today, the schizophrenia phenotypes has changed, but probably the concept has to go. And there's a long way for us to close and bury this. I still think bipolar type 2 depression will survive. But I would take positively what my dear friend MS Reddy, my neighbor, my brother, and we both actually collaborate together, has taught us today. It's a good kind of a message to us that, see, and last comment for me is, today the evidence is from the same CANMET guidelines, you can use, because there is an emerging evidence, you can use antidepressants, but carefully, that's the caution, along with mood stabilizer. I would agree with his, the paper which he presented, that in fact, antidepressants reduces the efficacy of mood stabilizers. For me, there is no mood stabilizer like him, which has evidence for more than 2 to 3 years. Realistically, rest of the studies, except the network analysis, group analysis of the bipolar group, we don't really have. And which pharma company is interested in doing this kind of double-blind long-term trials? Thank you very much. I think I've taken a lot of your time. But before I close, in my review, I have seen IVL Narasimha Rao's three cases presented in juvenile childhood bipolar depression. In the 3 cases which he published in the Indian Journal of Psychiatry way back, there is one case of classical bipolar 2, even in an adolescent. So with this, I close. Thank you, IPS AP chapter, for giving me the opportunity.
Thank you, Dr. Prasad Rao. Entire contradictory opinion from your brother, friend. And I think there is something in between. I mean, MS
No,
Reddy
it's not entirely opposite. I only said it's not to be buried.
No,
I said
yeah, definitely. And
it
not
is
even retire. Not even to retire.
retire.
That is my idea. And there are always 2 schools of thought. So MS belongs to that school, and you belong to this school. And there are definitely suggestions that bipolar 2 has to be there. And we have been treating from a long time. In fact, I disagree with Raman Rao on one contest where he said bipolar 2 is more comparatively mild because hypomania is mild. But the thing is, the depressive symptoms are more prolonged, last longer, the in between gap between the episodes is minimal, and mixed symptoms are there more common in bipolar 2. And even genetically, bipolar 2 disorder relatives have more evidence of bipolar disorders compared to bipolar 1. So, I mean, some studies suggest this. And one more question to MS Reddy sir from anonymous attendance. Sir, the whole confusion comes in when we have concept of bipolar disorder and we start worrying about depression, switch and mood stabilizers. Is it sensible enough to call it a mood disorder only and treat whatever the patient has at presentation rather than worrying about anything? And he also adds, in bipolar 2, in my short clinical practice, I noticed that lamotrigine augmentation with antidepressants SNRI work better than lithium and CBZ augmentation. It's more than 30 patients, SNRI better than SSRI, sir. Your opinion is needed, Dr. MS.
See, thank you very much. I think the first one is a very intelligent question. The concept of bipolar disorder itself, whether we can leave it. It may be difficult when you look at mania, because there has to be. See, we are going back to the maybe Kraepelinian concept, maybe suits what you said. Kraepelin, like one of the great proponents of this classificatory systems, when he talked about manic depressive psychosis, he included recurrent depressive disorders also under bipolar disorders, which was later separated out. But we do need to switch. Generally, we talk about only switch to mania. I think all of us have to look at switch to depression also, which is very, very frequently I keep talking about. So, mood disorder, under that subclassification is to see that whether we can achieve better results. That's the only thing. The reason why schizophrenia subtypes have gone over a period of decades, they could not see really much of a change in the results. That's why it is gone. I think that's where it stands, and beyond that, it's difficult. Lamotrigine, sir, that I think is a very interesting question. Whoever has asked about it, lamotrigine augmentation, two things are asked about. Number one, SNRIs works better than SSRIs. It's always difficult to say that. Theoretically, it looks SSRI is only serotonergic and SNRI is both combination. May not be the case all the time. But as a subgroup, whether the SNRI works better, I don't have that kind of an experience. I don't subscribe to that. Then coming to lamotrigine, in the last half an hour or 45 minutes now, whatever I have committed enough sin, let me not commit one more sin when talk about lamotrigine. I have stopped using lamotrigine, sir. Maybe sometime later we can talk about. It's an excellent, safe drug, but for that first 2 months of rash, that we have to be careful about. We all can get over that. But beyond that, in my opinion, does it do anything? Even the literature wise, there are some studies which showed it's effective. There are equal number of studies saying that it's absolutely useless in the management of that. Of course, I do know. Remember that CanMat even prescribes it as an acute stage of depression also, which I think find it very difficult. At this point, sir, maybe sometime any of you would like to discuss. I would like to talk about the natural course of bipolar disorder, which a lot of times I say the natural course of bipolar disorder, where extended periods of euthymia lasting for more than months or years without any intervention. Don't do anything. Recently, I had one patient. I'll take another minute, sir. The first time I saw the patient in 2013, that boy landed up in mania, got admitted, treated. Then I have a small spreadsheet where I keep recording that. 2 months only, he disappeared. Second episode came in 2023. And when I looked at it, 10 years, what happened? What happened? Sir, I'm all right. If I had started lithium, I would have been thinking it's because of lithium. If I had started lamotrigine, I would have been thinking it's because of lamotrigine. So natural course of bipolar disorder is very highly varied. We have to give a margin to that. And today, I feel lot of misconception is because they ignore the natural course. Prasad Rao brought out one point very, very today. I don't think any of us have a right to talk about prophylaxis in bipolar disorders because most of the studies are very abysmally low, 2 years or 3 years. A 10-year follow-up or crossover study is something which can tell us. Beyond that, a lot of times, a lot of people say, sir, we have given lamotrigine, it's working. It's a safe drug, especially the first 2-3 months you get over, no problem drug, but does it do anything good? I do not know. For me, it didn't work. It's like that. Somebody, it may be working because your clinical experience maybe, if you have more experience, maybe selective patients also. It could be a biased idea for me, but it doesn't. It did not.
Dr. G.V. Raman Rao,
Sir.
please,
Yeah,
your question, your comment and question, welcome.
yeah, sir. Regarding your, comments, sir, Suresh, sir, I'm talking about the stakeholders concept. Like, when somebody says I'm depressed, it's more accepted rather than when I'm maniac. And also number two, the maniac's natural destruction is more, naturally they are labeled in a different way. So most of the people with bipolar type 2, especially in the Western countries, because in India we don't really try to say whether type 1 or type 2, but in the literature it is mentioned that they feel comfortable in saying that we are having bipolar 2. That's one. Number two, I think regarding Emma's statement, of course, he spoke more of theory, treatment perspective. But when coming to the nosological, issues like why people are trending towards this dimensional approach from categorical approaches. That's true. Research is there. Now it has happened with autism. We have seen autism spectrum disorders. But what the hell is happening now? Every person with mental retardation is now they claim that it is autism. No, is it the right way to do it? They have clubbed all the five disorders into the autism spectrum disorders. At one end is the most severe autistic child. The other one is the Asperger's, who is having very mild autism and able to manage himself. So it's more of a nosological problem rather than a treatment issue like this burying type two. There are so many proponents of what Dr. MS was talking about. They don't want this type two disorder. But why in the 70s they have come out with type 2 and why now they say it's not relevant? I really didn't understand the logic behind that. Can you please elaborate, sir, about this logic? Why now they are denying that it's not relevant now?
Dr. MS?
Yeah. See, before I answer that, there is a question from my friend Dr. Ramesh Balaji.
Yeah. Two
I think
schools of
that's a
thought.
very, very relevant and important question. Balaji, thank you so much for bringing it out. Forget about all the schools of thought. What is the thing which students should follow? I'm very happy. When I talk this, I don't talk to my postgraduates. I even tell them, very consciously, I tell them sometimes you don't listen to me because tomorrow you go and tell, no, like Kota Suresh Kumar will fail you if you say that bipolar II disorder is a myth. No, 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 I'm not an examiner. Please don't follow this. This is only for your understanding and then raising the questions and nothing more than that. I think what you said is right. That is what. One of the unfortunate things is that, right, there's a school of thought, they have to learn that. And then when they come out of it, they have to look at the different perspective of it. I think Ramesh Balaji is right. That's why I'm a little bit cautious when I talk to the postgraduate sometimes. Now, see, I did talk about. Let's look at 70s. That's the time. It was manic depressive psychosis. From there, it is split into bipolar disorder and unipolar. Bipolar disorder at that time, even at Kriplin's time, the number of percentage of bipolar disorders is very low. CanMat, now like Lashmi Atham in his own book says that why did Kriplin combine bipolar and manic depressive? He says that possibly the bipolar disorders are very small number. To get the group bigger, he put this into Kriplin's classification of manic depressive psychosis includes bipolar plus recurrent depressive disorder. From that, it has split up. As I told that 70s, there could have been a feeling that some patients with bipolar disorder are being missed out because they have very shorter periods of mania. So to cover that, actually Benazzi is one of the research workers who fought entire life to reduce the duration from 4 days to 2 days. He wanted saying that 2 days of hypomania should be enough, 2 days of disturbance should be enough. So that is where they would have thought that some milder cases we are missing. So let us introduce another bipolar 2. That is the only, I can think about only that. But later the changes is, I don't think they would have thought about introducing irritability as a diagnostic criteria in DSM, which has done a huge damage. I don't think they would have been talking about the moment you talk about bipolar, there has to be lithium valproate. I don't think that was the thing. We, as students, we were not taught that. And I don't think at that point of time, SSRIs did not exist at that point of time. It's only the tricyclics, which had a huge side effects, where the rate of switch was much. This could have been the context because we have to look at the contextual thing when we look at it. That time, maybe it was relevant to get more focus, to see some patients who are getting untreated, getting into the treatment line. Now it's changed over a period of time. You have better drugs, the more concepts, more over-inclusiveness. There is a huge over-inclusiveness in bipolar disorders. Again, most of you may say that, no, like you are underdiagnosing. I say you are overdiagnosing. Borderline personalities are getting left, right, and center. The only reason, let me put out, why are you so bothered about the overdiagnosis? We all do that. We all make wrong diagnosis. My only point is, let the research workers, let the textbooks stop saying that. mood stabilization with bipolar disorder, I will not talk. The moment you diagnose bipolar disorder in a youngster of 17, 18 years, you talk about mood stabilization. You talk about one drug. If he relapses, 2 drugs. If you have 3 drugs, polypharmacy is the norm. And how long, doctor? A 17-year-old kid is going to have prophylaxis for the next 50, 60 years. Are we right? And especially if the diagnosis is wrong. If it is a serious diagnosis, definitely you go and do all out to do that. And at this point, once again, as I told that, no, you're making me commit more sins. I say that very definitely. Today, the available prophylaxis drugs are, most of them are useless. I did stick my neck out some time back, but for lithium, the so-called other mood stabilizers do not seem to be stabilizing mood. This is what the statement some time back I made. People didn't agree. People said it's a rash statement, but I still hold by that. I request only one thing to all of you, whoever it is there, whoever is interested. Select 10 patients in your clinic. Follow them up for the next 10 years, sir. A lot of your youngsters. Just select 10 patients with a clear-cut, elated, grandiose John Cates mania bipolar disorder. Follow them up for the next 10 years. You will see, amazed to see the variety. As I told you, 2013 first manic episode, second manic episode, 2023, what has happened? 10 years, what is the reason why this man did not have? How do we answer that? One odd case. Dr. Reddy, one odd case you're talking about. No, sir, this is not one odd case. Umpty cases I'm seeing. Cases are dismissed. Your one case, level 5 evidence, I agree. But I have hundreds of cases falling into that. Then where do I go? Do I believe your RCT, which is done for 2 years and then classifying them as prophylaxis drugs? Or do I believe the case is what my own patients following? Exactly. Again, I say that. Why did this patient have a 10 years euthymic period without any drug? How can somebody answer that? It's a bipolar, elated, grandiose, classical mania. These are the questions, sir. That's the only reason I said that, nothing else. You take out that mood stabilizer, disorder, from tomorrow I'll stop talking. I will not say anything. By diagnosing that, by putting a polypharmacy, which is a sin, lithium valproate lamotrigine, lithium valproate quetiapine, lithium valproate, it's a sin. For years, 1 year, 2 years, I agree. For decades, no, sir, it's not acceptable. It's not acceptable.
I think, Dr. MS, you have been partially successful in brainwashing a lot of people, but not completely. Still, we are there. A lot of people
You
to.
gave me the opportunity to put out my thought a little bit
Yeah,
more
yeah, definitely. It is
Raman
very
Rao and all this.
stimulating. I
Thanks.
mean, it is very stimulating, and we will refer a lot of things for that purpose. And I agree with you regarding irritability and keeping the
Yes.
hypomanic period for
Yes.
4 days is something really not cherishable. Definitely. That I would definitely agree. And Dr. Prasad Rao is waving his hands. Yes, Prasad?
No, I just want to tell you what the answer to the simplest answer for what Dr. MS Reddy asked. Not all bipolar patients have so many episodes. I also had similar kinds of cases. Each one of us would have. But having said that, we agree it's bipolar is so heterogeneous by definition itself. So that would explain. But there are also other genetic compelling biomarkers which we need to work and look into. And probably bipolar type 2 and other bipolar types as described by Akiskal also do exist in our clinics. But of course, I am very appreciative of what Dr. MS Reddy talked about, an abuse of pharmacotherapy, polypharmacy in bipolar. That's what I would like to close. Thank you
Sir,
very much.
let's all say it loud and clear. Abuse of polypharmacy. People talk about rational polypharmacy and then abuse left, right, and center. 3 mood stabilizers. Absolutely useless drugs going on for patients. Fortunately, patients stop the drugs. Fortunately,
Yeah.
patients don't listen to us. Now, I'm
Yeah.
telling out in this group, I'm sorry. Fortunately, they don't listen to us. This is a rash statement. I do agree. But this is what I have been going through for the last 1 decade, more than that. It's a silly.
Dr. Prasad Rao was mentioning about 3 cases that have been reported by our President, Dr. I.V.L. Narasimha Rao. So your comments, Dr. IVLG?
See, here we have an authority on bipolar, Dr. MS Reddy. See, whatever he says, we take it is like Gita word only. On bipolar disorder. On bipolar disorder. So he has a lot of experience in
Yeah,
bipolar.
that is true.
I
think
do
he's-
agree.
he's,
As clinicians who are interested in practicing only, will have only two entities. One bipolar disorder or MDD. We don't distinguish bipolar 1 or bipolar 2.
I think you are coming to a consensus.
Yes.
So,
I agree with MS Reddy.
okay, if my question to Dr. MS is, if you are saying bipolar 2 is not going to be there, you want to make it, you want to go back to 30 years back and say it's only one and treat.
See,
As you
it's
said, in
as I told,
70s,
sir.
bipolar 2 has been introduced.
See, it's like this, sir. Today, actually, thanks to all of you, I could talk about some of the things which are not otherwise I generally hesitate to talk about. You made me talk. My point is, I have stopped diagnosing bipolar 2, and I also stopped diagnosing mixed cases long time. I could be wrong. I could be wrong. But in my clinical practice, I am finding it a little bit not very conducive. And there are certain times which I feel that maybe I'm doing wrong. For the present, I am not doing it. The only thing what I say is that please follow up your cases. Then it's individual insight. And then the consortium, a bipolar consortium all over, is going to bring out a lot of things. Maybe next 2-3 decades are going to see huge changes. That's it. It's only that, nothing more than that. For all the youngsters, think about it. How long the prophylaxis? How old is the patient? How long is the hypomania? How much of social impairment? Am I right in putting this boy for such a long time? If it is justified, go ahead. And then keep observing it in a period of time. Nothing more than that. No. I definitely, this is the diagnosis which has come when a lot of senior and then very wise people have come to this. This is my viewpoint. Nothing more than that. That's it. Nothing more.
Dr. Ranjit, you want to ask some question? Share your feeling?
No, sir. I totally agree with what sir has been saying. I think though he has revolutionized and questioned and challenged everything we have been studying since so many years, I think it holds a lot of water because we're using polypharmacy for so many years, which is not really required, and the concept of irritability and all doesn't seem good for bipolar.
Dr. Prasad, waving the hand.
I was saluting you.
I thought you are waving and the hand appeared as if it is going to beat me.
No. I was saluting you for your way you are conducting chairperson and giving a kind of a stimulus, asking IVL to talk. See, ultimately, IVL can talk only with Suresh Kumar.
Jigri dost. Anyway, it was very stimulating. Any other want to question? Otherwise, the questions will go on with there because it's a very stimulating, controversial topic which Dr. MS has taken.
And there is one more question, sir. What about cyclothymia with episodic MDD misdiagnosis bipolar 2? Sir, let me not talk about cyclothymia now. It's one more area where there can be.
Yeah.
Let's hold on to that. Thank you so much. But that's an important question. Very important question. I agree.
So we are very thankful, Dr. MS, for sharing because you are the only person who has been well versed with bipolar. You have been seeing a lot of people from a lot of time, though we see occasionally and we don't follow up. You have been doing that, and definitely your word carries some value and it is of wisdom you are coming. But as I told you, it is somewhere in between. Prasad Rao, MS, in between, we are all there. And definitely we will follow your advice of keeping 10-year follow-up. If Lord gives me 10 years more lifetime, I will definitely try to follow. Anyway, thank you. Thank you, Dr. Ivy and Dr. Sharath, for giving me the opportunity to chair the session. And thank you, all the members. Thank you very much. And
Now
I think
we-
final words have to be mentioned by Dr. Raman Rao, sir. waving
Sir,
your
evening.
hand.
No, I think inadvertently it has raised. Anyway, I thank MS. But as Dr. Prasad Rao was telling, in fact, in my practice, because definitely polypharmacy is not advised, but when I suspect so-called bipolar type 2, I will prefer an atypical antipsychotic rather than adding any other things like atypical antipsychotic like cariprazine or lorazepam or a combination of fluoxetine, olanzapine, because that's okay because that won't really go for a long time, and we are avoiding the polyforms also. Even that is a good option, like because we can't just keep away this particular segment of patients who are having bipolarity definitely, and they are vulnerable for relapses, and we can't ignore them. We just can't ignore that particular segment of patient population. And unless the international community says that okay, the bipolar 2 is not existing, it's a reality. I feel it's a reality. Even irritable maniacs is not something abnormal. I feel irritable maniacs is definitely an entity, and of late we see more of irritable maniacs rather than elated maniacs, right from our PG days also. It is increasing day by day, day by day. And we don't see the classical maniacs of late. So this is how probably I feel in my day-to-day practice.
Thank you, Dr. Raman, for
Yeah, thank you.
your view of point is well taken. And as the time is moving on and the discussion will continue for a long time, because this being a controversial topic, we will end here. We will ask Dr. Sharat Chandra for vote of thanks.
Sir, I request Ranjit Kumar to propose a vote of thanks.
Fine.
I'm giving the
Dr.
vote
Ranjit,
of thanks. I would like to thank Dr. MS Reddy sir, the speaker, for making us all think and for stimulating us to think. I would like to thank Dr. Kota Suresh Kumar sir for chairing the session and giving a balanced view. I would like to thank Dr. J.V. Raman Rao sir, the CME committee head. I would like to thank Dr. Ivil Narasimha Rao sir, President of IPS AP State Branch. I would like to thank Dr. Ivil Sharath sir, Secretary of IPS AP State Branch. I would like to thank all the participants for patient listening. And lastly, I would like to thank Zonalta for sponsoring this program. Thank you, everyone. Good night.
good night. Good
Thank
night.
you. Thank you. Thank you.
Good night, sir. Good night, all of
Thanks.
you. Thank you very much
Good
for
night.
everything.
Thanks, sir.